Good evening and welcome, everyone. Thank you for taking time out of your busy schedules on a weeknight on a Tuesday evening to be with us today. My name is Mark Pegram from Stanford, California. I'm a medical oncologist. I've been asked by the organizers to review ASCO 2021 with a focus on early breast cancer data, as well as updates in extended endocrine therapy for hormone receptor positive early stage disease. Please note my disclosures. I'm a consultant for AstraZeneca and Biotheranostics, sponsors for whom I will show you some data tonight. So please take those disclosures into your consideration of the data presentation tonight. We have an ambitious agenda for you tonight. I hope to cover the ASCO plenary on the Olympia adjuvant Parp inhibition data, the Nodal data, which is tantalizing data showing single agent activity of Parp inhibition in the neoadjuvant setting for BRCA mutant patients. Nuevo, which will ask the question, can time to event outcomes resurrect immune checkpoint inhibition in early breast cancer? Nuevo is a small study, so not practice changing to be sure just yet, but tantalizing and provocative data that are positive that may give us hope for this approach in triple negative early breast cancer in the future. And finally, we'll focus a little bit on the NSABP B42 translational updates, which investigated both the HOXB13 IL-17B receptor ratio as well as the Mammoprint assay in outcomes on extended adjuvant aromatase inhibition in B42. So let's start with the ASCO plenary, the Olympia pivotal trial that is olaparib in adjuvant BRCA mutant breast cancer, a phase 3 multicenter randomized placebo-controlled trial of adjuvant olaparib after neoadjuvant or adjuvant chemotherapy in patients with germline BRCA1/2 mutations and high risk that have HER2 negative early breast cancer. I forgot to mention that during the course of this presentation, after each topic, I'm going to pause for questions and answers, which you can participate in through the chat function. We'll be monitoring those in real time. And then my able assistant, Lisa, will raise one or two of your questions, time permitting, after each section. I'll pause briefly to take questions. So the scientific rationale for the Olympia trial is based on the concept of synthetic lethality that was first published by Alan Ashworth and colleagues, demonstrating that BRCA mutant cells cannot tolerate Parp inhibition, and the synthetic lethality in patients who have this BRCA deficiency cannot repair double-stranded DNA breaks. Proof of concept for this approach has been demonstrated in the metastatic setting by the Olympia study on the top right, as well as the Embraca study also in the top right in the lower panel. Both of these studies met their primary endpoints with statistical confidence in patients with metastatic disease. The PFS hazard ratios were 0.58 and 0.54 respectively, and there were significant improvements in health-related quality of life outcomes, but no overall survival benefit in these studies reported as yet. So this is the Olympia trial scheme. These are patients with local genetic testing or on study central screening at Myriad, germline pathogenic or likely pathogenic BRCA 1 or 2 mutations, HER2 negative, but they could be hormone receptor positive or triple negative, stage 2 to 3 breast cancer, or those patients who do not achieve a path CR following neoadjuvant chemotherapy. The neoadjuvant group was high risk based on the fact that the triple negative patients were included only if they did not achieve a path CR. The hormone receptor positive patients also had to have no PCR and a clinical pathologic score plus estrogen receptor and nuclear grade score greater than or equal to 3. So these are high risk groups to be sure in the neoadjuvant setting. Moreover, the adjuvant group was also high risk. For the triple negatives, they had to be at least PT2 or PN1 or greater to be eligible, or for the hormone receptor positive subgroup, greater than or equal to 4 positive lymph nodes was required as eligibility criteria. The patients were randomized 1-to-1. There were 1,836 such patients randomized to olaparib 300 milligrams BID for 1 year versus placebo. The primary endpoint was IDFS by steep definition. Secondary endpoints are shown, as well as the stratification factors. These are the top-line data shown on the upper right. This is the primary outcome of IDFS. At 2.5 years median follow-up, the IDMC recommended data unblinding as an interim analysis had shown that a significant benefit from olaparib versus placebo had emerged for the IDFS endpoint. Distant disease-free survival was also significantly improved with olaparib with a stratified hazard ratio of 0.57, which was significant. Overall survival was numerically prolonged with olaparib, but this was not statistically significant based on threshold p-value pre-specified to be less than 0.01 in the alpha spending plan, and the observed p-value for the hazard ratio of 0.68 was 0.024, so not quite statistically significant at this data cut for the OS endpoint. Nevertheless, impressive outcomes for the primary endpoint of IDFS, to be sure. The author's conclusion: 1 year of adjuvant olaparib following local treatment and neo or adjuvant chemotherapy significantly improved IDFS and distant disease-free survival with acceptable toxicity in patient with germline BRCA mutations and high-risk HER2-negative early breast cancer. How about the safety? There were no new safety signals based on what was expected from the metastatic disease BRCA mutant experience. To be sure, this PARP inhibitor, olaparib, does cause GI toxicity in the form of nausea, vomiting, or diarrhea that is higher than the placebo group. And so for selected patients, antiemetics or perhaps even dose modification may be indicated. Moreover, fatigue is seen more frequently in the olaparib randomized subjects as compared to placebo. And there are some other adverse events that are also increased, particularly hematologic endpoints. There's significantly more grade 3 anemia in the olaparib group compared to placebo. And there's also some increase in neutropenia and leukopenia as well. In addition, as you might expect from GI toxicities, anorexia is also a feature of the safety profile of olaparib. The discussant was Nadine Tung, who did a very nice job in summarizing this data set. She noted that the addition of olaparib to standard therapy improved 3-year IDFS and distant disease-free survival for BRCA mutant carriers with HER2-negative breast cancer and triple-negative disease that were high risk, or hormone receptor-positive disease that were high risk, or those not achieving PCR after neoadjuvant chemotherapy with higher tumor burden required for the hormone receptor-positive HER2-negative subgroup, as I showed you at the top of the hour. There are no new safety concerns. There was no increase in myelodysplasia or AML. I put a qualifier after this bullet, yet. We need longer follow-up to be sure to see whether these events might emerge with longer follow-up. The results are considered to be practice-changing potentially if this wins approval by regulators. This has implications for germline DNA testing in the modern era, and it kind of turns the question on its head. We now ask in clinic, who should we test for evidence of BRCA germline DNA mutation? But now the question maybe should be, who shouldn't be tested now that we have these extraordinary efficacy results based on the Olympia data, which hopefully will win regulatory approval and be available for therapeutic consideration in the not too distant future. Also at this ASCO, we saw this neoadjuvant study of a single agent PARP inhibitor, Talizab, with the doses and schedules shown in the fine print at the top of the schema. And I'm showing you the path CR rate for single agent PARP inhibition for the evaluable population in blue and the intent to treat populations shown in green. The results between those two populations are highly similar, as you can see. And also I'm showing you on the left the PCR as adjudicated by an independent committee review versus the investigator reported PCRs on the right-hand side of the slide. The bottom line here is single agent PARP inhibition in BRCA mutant carriers is very active with a very impressive PCR rate, rivaling that perhaps of what one might expect from a chemotherapeutic indeed in this patient population. This was a non-randomized open-label multi-center single-arm phase 2 study. So, intriguing, though perhaps not practice-changing just yet, but it does, it is consistent with the adjuvant data that I've just shown you, and it shows you dramatic effects on early breast cancer with a single agent PARP inhibitor in a neoadjuvant early stage breast cancer clinical setting. I'll pause there for brief questions. Lisa, is there anything in the chat just yet before we move on to the next topic?
Yes, Dr. Pegram. So the first question is, would you consider PARP inhibition for BRCA somatic mutations?
Yeah, it's an excellent question. That question can't be, cannot be determined on the basis of this data set, which is all germline. So I think we need more data on that topic before we can make any declarations regarding somatic. But in theory, there is ample reason to believe that it may be impactful, but we need clinical data before that becomes, practice changing.
And thank you, Dr. Pegram. The next question is, in triple negative BRCA patients, should we be using adjuvant olaparib or cetabixine or both after neoadjuvant chemotherapy?
That's an excellent question. Based on the CREATE-X trial, we know that you can get benefit in triple negative breast cancer patients who don't achieve a PATH CR. And this question came up during the Q&A with Andy Tutt, the presenting author. And what he pointed out, I'll show you, is interesting. He pointed out these curves break very early in Olympia, and he suggested that might suggest that Parp inhibition might be something as a go-to first if you're going to use post-neoadjuvant capecitabine, and maybe save the capecitabine for later consideration if you're going to try to do both, let's say for a locally advanced triple negative disease that does not achieve a PATH CR, for instance. So that's a great question. We don't have any data yet on one of these agents following another, much less the order in which they should be considered. So no definitive answers can be offered at this point, except Professor Tutt's observation of an early break in these curves in the case of the Parp inhibitor.
Wonderful. So Dr. Pegram, we do have a few other questions, but we will hold those till the end.
Yeah, perhaps we have time at the end. That's great, thank you. Next, let's talk about immune checkpoint blockade, which of course was recognized by the Nobel Prize Committee back in 2018 for Professors Han Zhou and Allison. And the Gepard-Nuevo data was presented, updated, I should say, at this ASCO, having been presented previously for just the PCR endpoint, which was a bit disappointing, actually, not reaching statistical significance even. But this was a phase 2 randomized trial. Patients were randomized to receive anti-PD-L1 checkpoint inhibitor durvalumab, 1.5 grams IV every 4 weeks, or placebo. This was given in combination with nab-paclitaxel and epirubicin cyclophosphamide on the doses and schedules shown. The primary outcome was pathologic complete response, defined as YPT0, YPN0. Secondary outcomes are shown. There were just a total of 174 patients enrolled between 2016 and 2017. So not a large trial, only 88 in the durvalumab arm and 86 in the placebo arm. That said, the PCR rates with durvalumab and placebo were 53.4% and 44.2% respectively, for an adjusted odds ratio of 1.53. This did not achieve statistical significance with a p-value of 0.182. That had been previously presented and was somewhat disappointing because it had been hoped that durvalumab would increase the PCR rate, but this data set did not demonstrate that. However, now with longer follow-up and availability of time to event outcomes, including IDFS, distance disease-free survival, and overall survival, the addition of durvalumab to neoadjuvant chemotherapy significantly improves survival for IDFS, hazard ratio of 0.48 with statistical confidence, DDFS, hazard ratio of 0.31 with a significant p-value, and overall survival hazard ratio of 0.24 with a significant value on the p-value there, also 0.01. So patients achieving PATH CR also had improved survival with durvalumab compared to PCR rates on placebo, as shown in Figure 1. In Figure 1 on the lower right, you can see that the PCR patients for durvalumab are shown in pink, and the placebo arms are in blue. So the top pink line are the PCR durvalumab patients. The lower pink lines are the non-PCR durvalumab patients. The top blue line is PCR placebo, and the bottom line is placebo non-PCR, as you might expect. Note that for both PCRs and non-PCRs, the IDFS, DDFS, and OS curves are higher, both in the PCR groups and in the non-PCR groups, as reflected by the intent to treat analysis in the text above. So pretty impressive data for all of the time to event outcomes shown in this study. Now, this is juxtaposed to the recent ODAC decision which in a 10-0 vote, the FDA Oncology Drug Advisory Committee did not support the approval of pembrolizumab based on the KEYNOTE-522 data for high-risk early-stage triple-negative breast cancers. The vote was unanimous. The ODAC group determined that the survival findings were immature and required longer follow-up. The committee also noted that PCR has not been established as an endpoint that's reflective of clinical benefit due to uncertainty revolving around its relationship to event-free survival and overall survival. So to remind you, KEYNOTE-522, this is the graphical abstract from the New England Journal paper published by Schmidt and colleagues. And I've corrected this slide because although it says in the upper left, there were 1,174 patients, the New England Journal paper was only on the first 602 patients. And the results changed as the data matured with inclusion of all 1,174 patients. So while these data published look pretty impressive, including increases in PCR, which were statistically significant, improvements in event-free survival, and some increase numerically for grade 3 adverse events, nevertheless, impressive results at the time of what was an interim analysis, in essence, for KEYNOTE-522. Now, with longer follow-up of all patients, and this is the data that the ODAC had available to them at this time, the most recent interim analysis shows that the PCR rate difference between two arms has decreased down to only 7.5%, not the 13.6% reported in the New England Journal of Medicine. The event-free survival endpoint had not met its pre-specified threshold for statistical significance and remained immature, with only about half of the targeted EFS events having yet occurred. More patients who received pembrolizumab compared to placebo experienced immune-mediated adverse events or infusion reactions, and there were 4 deaths in patients who received pembrolizumab, which were potentially due to immune-mediated adverse events. Increased immune-mediated adverse events, some of which were severe or irreversible, requiring lifelong medication, occurred in potentially curable and otherwise healthy patients. And so the design and results of KEYNOTE-522 did not currently support a role for neoadjuvant pembrolizumab, according to the ODAC. So this raises the question, can Gepar-Nuevo rehabilitate 522, and will longer follow-up with 522 result in event-free and perhaps overall survival endpoints that do achieve statistical significance in the long run? That remains to be seen. Like the Gepar-Nuevo study, the PCR rates are only marginally different in KEYNOTE-522 now with full enrollment of the trial, which I find interesting also. So it begs the question, is there an association or not between PCR and long-term time to event outcomes with immune checkpoint inhibition in triple-negative breast cancer? Now, what we've done so far with immune checkpoint inhibition in solid tumor oncology is shown in this slide, and this is an actual development strategy from a single sponsor who has a checkpoint antibody. And you can see all the dark circles are different types of tumors, and all of the shaded, lighter colored boxes are individual clinical trials within that disease. And so you can see this is just throwing checkpoint inhibitors at the wall to see what sticks without regard to any scientific merit or preclinical data in support of most of these trials. I was at a keynote address by Jim Allison just a few years ago. He was highly critical of this strategy, noting that in most of these trials, they aren't even acquiring specimens for analysis, much less doing any translational work that would result in any meaningful predictor for response to immune checkpoint inhibition in solid tumors. So this was all very disappointing. I want to point out that we now have new technologies that are available to evaluate immune repertoires within tumors, both at the time of diagnosis and following treatment with immune checkpoint inhibition. I think you probably need to understand the infiltration of various subpopulations of immune effector cells, not only at the time of diagnosis, but also following treatment, because immune responses are very dynamic. Cell-to-cell contacts can be changed, and they can now be measured using either multiplexed ion beam imaging in human breast cancers. This is a publication from the group at Stanford on the far left, showing that you can understand immune repertoires, including cell-cell interactions, to a high degree of precision in human tumor specimens. Also, there is a commercially available technology developed at Stanford called Codex, which uses DNA barcoding for different detection antibodies that can also classify tumor-infiltrating immune repertoires with high precision and including cell-cell contacts as well, And this is commercially available with human reagents. And so these technologies ought to be applied because PD-L1 clearly is not the marker for immune checkpoint inhibition in breast cancer, in my opinion, is a marker in metastatic disease perhaps. But you'll notice a consistent finding of all the neoadjuvant trials is that PD-L1 status does not actually matter in terms of triple negative breast cancer, at least in the neoadjuvant setting. So there must be other markers out there that remain to be discovered, in my opinion. I'll pause there for any questions on this topic of immune checkpoint inhibition. Lisa, anything coming in through the chat?
Nothing at this point, so I think we can continue based on time, and we'll circle back to some of these additional questions towards the end.
If you think of questions along the way, please just enter them into the chat, and this is being harvested in real time as we go, and at least we'll post them all to me time permitting at the end. Next, let's talk about breast cancer biomarkers. We are now firmly entrenched into the multi-gene assay era, having gone through the era of using the estrogen progesterone receptor, perhaps markers of proliferation like Ki67, and certainly HER2 receptor as a marker for predictive evaluation in response to HER2 targeted therapies. And so among the multi-gene assays, historically, it started out with the famous paper by Peru, published from here at Stanford, published in Nature back in 2000, the molecular portraits of human breast tumors. You've seen this heat map 1,000 times at least. There's probably not a breast cancer lecture that's been given since 2000 that hasn't shown this image on the lower left. Subsequently, in 2002, Vanderveer and colleagues published the New England Journal paper with a 70 gene signature Mammoprint shown in the heat map just below the text in the middle of the slide. Peg and colleagues also published a paper in the New England Journal of Medicine on the Oncotype DX assay, the 21 gene assay, 16 disease-related genes broken into categories of proliferation, HER2, and ER dependence, as well as 3 marker genes that are associated with prognosis, and then housekeeping genes as controls. And you know that this is a multiplex real-time PCR assay that has great precision and has both prognostic and predictive value for response to adjuvant chemotherapy. Ma and colleagues in 2004 elucidated the HOXB13 IL-17B receptor ratio and its ability to predict outcome in patients treated with tamoxifen. It's important to point out this is also done with a 20,000 element, unbiased, unsupervised array technology. And so this was completely unbiased, and as opposed to Oncotype DX, where the genes had already been known and characterized and in many cases published. More recently, Sperano and colleagues and Kalinsky have shown more data on the Oncotype assay and its use in the intermediate risk recurrence score group in the TAILORx trial, as well as the responder trial evaluating its utility in patients with 1 to 3 positive lymph nodes. That data was presented at San Antonio, so in the interest of time tonight, I'm not going to have a chance to go through that, but hopefully you're familiar with these results and are applying those already in clinical practice. So just to go back and circle back to the HOXB13 IL-17B receptor expression in early stage breast cancer, this is the publication by Xiaojun Ma in 2006 in the JCO showing kind of the power of these markers, HOXB13 and IL-17BR. If you compare them for these hazard ratios for relapse-free survival on the left, you can see that IL-17BR has a similar prognostic ability as does steroid receptor expression based on these hazard ratios. And HOXB13 is in the opposite direction. And if you take the ratio of B13 to IL-17BR, it's even a higher hazard ratio. And look at these p-values for the ratio, 9 times 10 to the minus 6, for an interquartile hazard ratio of about 1.5. On the right-hand side of the slide are the validation studies in this paper showing that in 2 test sets of ER-positive node-negative patients, you can see that the ratio was predictive and for prognosis in these tamoxifen-treated and untreated cohorts in B and A, respectively. So after the prognostic ability of this 2-gene ratio had been established and validated, it investigators went on to look at the utility of this two-gene ratio in predicting outcome for extended adjuvant endocrine therapy. The Stockholm trial showed a significant relative risk reduction with statistical confidence for those patients that had a high HOXB13 to IL-17 BR ratio. MA17 compared tamoxifen followed by extended adjuvant aromatase inhibition versus placebo. This also showed a 65% relative risk reduction with statistical confidence in the BCI high group, but not in the low group. The same was demonstrated for 5 years of tamoxifen followed by 5 additional years of tamoxifen in the TransAtom trial. Also a similar risk reduction, 65%, very consistent with MA17 and seen only in the BCI high group. And the ideal trial was AI followed by either 2.5 or 5 years of AI. This is the only trial to test AI followed by AI with the 2-gene ratio. And it showed a similar 58% relative risk reduction with statistical confidence for the high HOXB13 to IL-17 BR ratio group, providing level 1B evidence as a predictive factor for response to extended adjuvant endocrine therapy with either AIs or tamoxifen. So with this background, Terry Momunos and colleagues from the NSABP presented this data at ASCO, looking at the 2-gene ratio and prediction of benefit from extended aromatase inhibition and the NRG NSABP B42 adjuvant trial. You'll recall this trial included postmenopausal patients with steroid receptor positive disease, stage 1 through 3A, disease-free after 5 years of endocrine therapy, with either AI for 5 years or TAM for up to 3 years and AI to complete 5. These patients were stratified by pathologic nodal status, prior adjuvant tamoxifen, and bone mineral density T-score, and then randomized to 5 additional years of letrozole versus 5 years of placebo in the original study design. You'll recall that back in 2016, when this data set was first presented, the results did not reach statistical significance. Although there was a hazard ratio of 0.85 and a p-value less than 0.048, the level of significance did not achieve the pre-specified 0.0418 that was required to declare this a positive trial. So from the get-go, this suggested to me that the event rate is fairly low, and consequently, the power of this trial is relatively modest to elucidate differences, even though there were interesting trends at the time of this first presentation. Subsequently, the 10-year follow-up data has been published and has now reached statistical significance for the primary endpoint in the intent to treat population. But it just shows you the importance of statistical power, which is driven solely by the event rate, not by the total number of patients enrolled. You can see here there's an extraordinary number of patients enrolled, over 1,900 patients per arm, and yet at the time of first presentation, it still did not reach statistical significance. Now, when you do translational science, starting with the original eligible B42 cohort, again, over 3,900 patients, sadly, the number of patients for whom there are available biospecimens is markedly lower, down to 2,345. So a priori, that's going to challenge statistical power for any translational endpoints that one may want to evaluate. Moreover, patients who had samples sufficient for BCI testing was down to 2,184, and the final translational cohort was 2,179, so well short of the ITT population of 3,900 and change. The reasons that patients dropped out are shown on the right for your consideration. The usual insufficient sample material or assay quality control issues. Now, when you compare the B42 translational cohort to those that were excluded, you'll notice that in this particular translational population, the risks are somewhat different. These patients tended to be a little bit older, and this was statistically significant. They tended to be more patients with node-negative disease in the translational cohort, and also more patients that were HER2 negative. All 3 of these reached statistical significance, and all 3 are trending in the same direction. So although the differences numerically may be fairly subtle, I was concerned when I first saw this data set that all three of them are trending in the wrong direction in terms of expected numbers of events, which may further challenge statistical power in drawing meaningful conclusions of subsets based on biomarker interrogation. The primary endpoint for this translational experiment was a recurrence-free interval, which is the time for randomization to breast cancer recurrence. The secondary endpoints of distant recurrence, disease-free survival, and breast cancer-free interval were also analyzed. Now, in the translational cohort, considering all patients, placebo versus letrozole, you can see that for the recurrence-free interval primary endpoint, the statistical significance has already been lost in the all-patient cohort. It has a ratio of 0.77, the p-value marginal at just 0.1. So again, this demonstrates the challenge of doing translational science with limited tissue resources when there are low event rates. Even despite large sample sizes, this can be a challenge. So in this analysis, when patients with a BCI HO/I high were analyzed, the hazard ratio is 0.83 with a non-significant p-value. BCI HO/I low, hazard ratio 0.69, p-value also insignificant at 0.13. The test for treatment by BCI interaction p-value was also non-significant at 0.55. The extended letrozole treatment effect in subgroups based on nodal status prior to tamoxifen use and HER2-TAZ was also not different by BCI H/I, and I'll show you some of that data, though not all of it in the interest of time. Another feature of this data set, which is interesting, is the carryover effect from the first 5 years of adjuvant endocrine therapy, which extends for about 4 years, as shown in the left in B42. You'll recall from all the early adjuvant tamoxifen studies that the benefit of tamoxifen continues well beyond the first 5 years, even when you stop the drug at year 5. And the same is true for aromatase inhibition in B42, as shown on the left in the red circle. This is not unique. This is seen on in many of these extended adjuvant endocrine therapy trials. The ATOM trial had the same feature as shown on the right for your consideration. So this is comes as no surprise for those of us in the field that are used to looking at these long-term extended adjuvant endocrine therapy data sets. So in the B42 parent trial, a delayed treatment effect of extended letrozole treatment on distant recurrence at around year 4 was observed. The proportional hazards assumption was not satisfied for the BCI high group, and this was statistically significant. So based on that, the statistical plan calls for a time-dependent secondary analysis for distant recurrence, and that was performed, and that's what I'll show you next. So in time-dependent secondary analysis for distant recurrence, you can see the BCI high on the left, and the time-dependent analysis after the first 4 years had a hazard ratio of 0.29 with a p-value of 0.003. However, BCI low on the right-hand side has a ratio of 0.68 with a p-value of 0.28, which is not significant. Statistically significant extended letrozole therapy benefit for distant recurrence in the BCI high group was observed after year 4. However, the extended letrozole therapy by BCI H/I interaction was not statistically significant for any of the time intervals greater than or less than 4 years, with only marginal p-values between 0.09 and 0.14 as shown. So again, when you're looking at subgroups of a translational cohort that has statistical power challenges, you may not be able to demonstrate significant interaction p-values just based on power considerations alone, in my opinion. Time-dependent secondary analysis by nodal status, you can see that the event rate is higher in the node positive group. So in the BCI high group, there is a greater difference again in the curves on the left lower the left lower plot, and the right lower BCI low was insignificant. However, neither of the extended letrozole therapy by H/I interaction terms were statistically significant for any of the subgroups at any of the time intervals in this analysis of node negative and node positive patients. That said, the time-dependent secondary analysis of distant recurrence by HER2 status was a little bit more interesting, in as much as the HER2 negative group had a statistically significant extended letrozole therapy by BCI H/I interaction for the HER2 negative subgroup after year 4. And in this case, it achieved statistical significance with a p-value of 0.043 in the HER2 negative group. The HER2 positive subgroup in B42 was only about 14% of the total patient population. So the numbers are very small and the numbers of events are even less. And so due to a limited number of patients with HER2 positive disease, it is not possible to make any declaration about the utility of the breast cancer index in HER2 positive patients in B42. But the HER2 negative group here did have a significant interaction term, and it's consistent with some of the previous published extended adjuvant endocrine therapy studies ranging from MA17 to ideal to transadjuvant. Another challenge of B42 is shown on the right, and that is a key difference of B42 versus previous breast cancer index studies is the proportion and contribution of contralateral disease to the treatment effect. In the bottom right, you can see the B42 trial, 54% of the events were from contralateral new primary breast cancers. And that's in contrast to MA17 transadjuvant ideal that had a much lower contribution of contralateral new primaries to the events. And again, a summary of MA17 transadjuvant ideal and B42 is shown for your consideration on the far left, and B42 did not have significant interaction p-values for the primary endpoint as I've shown you. However, I'm very concerned about this contribution of contralateral new primary endpoints in B42 being over half the events. And that's because you can't expect that a biomarker in a primary tumor would have any impact or ability to predict contralateral new primary breast cancers unless it were a DNA-based assay looking for the likes of BRCA mutations, for instance. So it's no surprise, since there were so many of these contralateral events, that they really contaminate the ability to interrogate BCI H over I, which has no ability to discriminate the risk of new contralateral primaries, to be sure, because that's not what the test was designed to do at all. It was designed to look at prognosis in ER-positive early disease, and it's been evaluated to interrogate benefits of extended adjuvant endocrine therapy. But it is handicapped in B42 by so many events being out of the purview of this two-gene ratio. So again, this is a formidable statistical challenge, since many of these events would be expected to not be impacted by this particular biomarker. So in post hoc analysis, powering of B42 is interesting. It only had about 50% power compared with about 88% in the ideal trial. Moreover, on the right-hand side of the slide, you can see the treatment effects in B42 were much more subtle, only about a 2.1% treatment effect on distant recurrence, whereas the ideal trial had more than double that at 4.6%. And again, the box on the left underscores the B42 high contribution of contralateral new primary breast cancers. Also, patients were predominantly higher risk in ideal, 73% node positive, and predominantly lower risk in B42, 60% node negative. The treatment effect is largely driven by a change in distant recurrence, which was attenuated in B42 compared to ideal, as I showed you, leading to a smaller effect size for the recurrence-free interval. So the author's conclusions are as follows. BCI HRI prediction for extended letrozole therapy benefit on recurrence-free interval could not be confirmed. The relapse-free interval absolute benefit was 1.6% in the B42 translational cohort. In time-dependent distant recurrence analysis, BCI H over I high cohort showed statistically significant benefits from extended letrozole therapy after year 4, while BCI low did not. The absolute benefit after year 4, comparing BCI high versus the unselected cohort, is consistent with previous validation results. And the BCI HRI prediction of extended letrozole therapy benefit after year 4 was more apparent in the HER2 negative subset, with a treatment by BCI interaction p-value that was significant. Additional follow-up is ongoing and may enable further characterization of this biomarker and predictive ability in B42. I'll pause there briefly. This is a very dense data set with many statistical caveats. And so I want to take questions now on the B42 translational subset analysis, and then we'll move on to the Mammoprint data last.
Yes, Dr. Pegram, one of the questions that came in earlier was, what is the usefulness of breast cancer index in a triple positive patient?
Again, in many of the studies that I've shown you, they're similar to B42 with only a small fraction of patients that are HER2 positive. And so none of those have enough statistical power to formally interrogate the utility of this assay in HER2 positive patient populations. That said, all the studies did include HER2 positive patients because they were accrued prior to the era of adjuvant trastuzumab, which commenced back in 2005 when the adjuvant data were first presented publicly and approved by the FDA. So, you know, we need more data, and there are studies planned to look at this in more detail in HER2 triple positive populations, but they were included in all the studies that I've shown you, but there are insufficient numbers of those to look at them as a subset and expect to see anything that's statistically significant because a very small number of patients with HER2 positive disease in all these cohorts, and smaller still the number of events in those cohorts in HER2 positive subsets. Great question.
Dr. Pegram, the next question is, practically speaking, how should we use breast cancer index, and specifically what types of patients?
You know, it's one of the most difficult decisions we face in our clinics these days. You know, that plus the use of chemotherapy in low-risk node-negative populations, which now has largely been made easier by the likes of the Oncotype DX assay, et cetera. So this has become one of the most complex decisions because taking adjuvant endocrine therapy is not easy. There are many adverse events. Of course, patients on tamoxifen have the risk of thromboembolic disease, as well as endometrial cancer, not to mention hot flashes, et cetera. So this is very upsetting to patients that have these complications, and the complications continue to accrue during the second 5 years in the ATOM trial and the Atlas trial. The numbers of those events kept going up throughout the extended tamoxifen treatment. Same is true for extended adjuvant AI. There are many problems associated with aromatase inhibition, bone mineral density being the most important, arguably, as well as myalgias and arthralgias, which can be severe and very upsetting in a fraction of patients. And these events also continue to mount in the second 5 years of aromatase inhibition, including pathologic fractures continue to mount. So this is a very difficult decision. Some patients that I find in my practice are determined not to take more than 5 years, no matter what you recommend, even if they have high risk, let's say locally advanced disease. Some patients just absolutely refuse to go on because the adverse events are just unbearable after absorbing them for such a long period of time. They can't contemplate the idea of moving further. So for those patients, this assay probably, you know, would be hard pressed to change anyone's mind. For more intermediate risk patients, I'm a data-driven clinician. Rather than just guessing, I like having evidence-based data to make these types of decisions. So I tend to show data to patients in my clinic if they have a background with whatever their profession they might be in, to understand some of the outcome data from the predictive trials. And I find that's very enlightening and can make a difficult decision easier for patients in my experience. The very low risk patients, there may be some that have very low risk for whom enthusiasm for additional molecular testing may be limited, especially if they have, you know, microinvasive disease and a background of DCIS and the like. Those also may be off the table for extended adjuvant endocrine considerations.
So Dr. Pegram, one last question. Prior to the challenges that you presented with the B42 data, would you continue to use breast cancer index to inform the decision to extend endocrine therapy based on some of the caveats you just provided?
Well, that's a great question. And so the B42 data, with its limitations, doesn't undo all of the other trials that have interrogated the BCI and extended adjuvant endocrine data sets. And so the guidelines committees have weighed in on this decision, and the NCCN has categorized all of the commercially available multi-gene assays shown in this slide. And the only one that's been selected to have predictive benefit for extended adjuvant endocrine therapy is the BCI, with a level of evidence of 2A. This year, based on the strength of MA17 Transatom and the IDEAL study, the NCCN has recognized the two-gene ratio in their current edition, January 2021 practice guidelines. So this august committee has recognized these previous data sets, and I suspect that the strength of these data sets is unchanged by B42, which had a number of statistical challenges, as I've outlined. We have just a little bit of time left to go over
let's go ahead and continue, and if we have additional time, Dr. Pegram, I'll circle back to some of these additional questions.
Fantastic. Let's talk about the Mammoprint assay. It was selected on the basis of 78 untreated node-negative primary tumors, 44 without relapse at 8-year follow-up, and 34 with relapse within 5 years. This was distilled down to a 70-gene poor prognosis signature, shown by the heat map on the right in a validation cohort of 295 partially treated node-negative, node-positive tumors. You can see the outcome between the good signature and the poor signature by the Kaplan-Meier plot on the far right. All this is published data in Nature and New England Journal of Medicine back in the early 2000s. Much of what we know about the utility of this assay was informed by the MINDAC study, a huge study involving patients who had clinical risks assessed by the old Adjuvant online tool, and all of whom had genomic 70-gene signature Mammoprint assays. And for those patients who had clinical low risk and genomic low risk, they were not given chemotherapy. They were given standard adjuvant endocrine therapy according to standard of care. Those patients with clinical high risk and genomic high risk on the far right, all of those patients were given chemotherapy because it would not be ethical to randomize them to a non-chemo option, of course. However, the discordant groups, the clinical low genomic high and the clinical high genomic low, were randomized to receive chemotherapy or not in this study to see whether there would be predictive value of the Mammoprint in these discordant cohorts. And of course, all of the hormone receptor positive patients went on to receive standard adjuvant endocrine therapy after completion of chemotherapy. Now, there were 11,288 patients who were screened at the time of surgery. There was a high dropout rate of about 40%, so 6,693 enrolled, still a huge sample size. It's always a little bit disconcerting to see high dropout rates in any data set. It always should beg the question, how representative is the data set to patients in the real world? But with such a high number enrolled, I think that's probably less of a concern here, but it is a particularly high dropout rate to be sure, as published in the New England Journal paper. Now, the primary endpoint analysis population for MINDAC was those patients with clinical high risk but genomic low risk who did not receive chemotherapy. And this endpoint was met with statistical confidence with an observed 5-year distant metastasis-free survival rate of 94.7% and a lower confidence bound that excluded 92%, which was the null hypothesis set at 92, which was based on survey data from breast cancer survivors from patients in the Netherlands, actually. So it's interesting to note with the lower confidence bound of 92.5, if that survey would have come up with a null hypothesis of 93 or 94, this data set itself might have been challenged with respect to its primary endpoint. So it's fortunate that the null hypothesis was set at just 92, which is actually not that good a risk in the modern era, one might argue. Now, with respect to the predictive value in the clinical high genomic low patients, you would expect that the genomic low patients would not benefit from chemo. However, if you look at the disease-free survival in the middle column, that actually had a hazard ratio of 0.64 and did achieve statistical significance. Now, the difference was subtle, to be sure, and so that's not my point. But my point is that you would expect that there would be no benefit of chemotherapy in these genomic low patients, and yet there was an observed effect. This has subsequently been updated to include differences between postmenopausal and premenopausal patients, similar to that noted in prior trials of the Oncotype DX. And some of this may be an impact of chemotherapy on menopausal status, causing amenorrhea, resulting in a treatment effect. Now, in the clinical low genomic high, where you might expect that there should be a benefit from chemo, For the distant metastasis-free survival, DFS and OS, none of these achieve statistical confidence, despite some hazard ratios less than 1. All the p-values on the far right are non-significant. So this study did not achieve one of the goals of MINDAC, which was to hopefully demonstrate predictive value of the Mammoprint assay for chemo response in these discordant groups. Now, these groups were also challenged by low numbers of events, as you can see. And so these were relatively underpowered to make definitive determinations, but certainly the trends were not in the right direction, no matter how you cut the data. Now, perhaps this null hypothesis of 92% has gotten back to the investigators from the MINDAC trial. And now there's a new classifier called ultra low risk with the Mammoprint, which is just a different cut point using the same 70 genes. And these patients do extremely well, irrespective of what adjuvant treatment they might have had or not. And so this question of ultra low was put to the test in subset analysis in the B42 trial, as was the 70 gene Mammoprint high versus low risk groups as well. The primary endpoint was distant recurrence. Secondary endpoints are shown. I've already shown you the schema for B42, so we won't go through that again. If you could look at the Mammoprint high on the left and Mammoprint low on the right, and these are the conventional high and low categorization that you might expect from the commercially available assay. You'll notice that the test treatment by Mammoprint risk group interaction p-value was not significant in this data set with a p-value of 0.38 for the primary endpoint of distant recurrence. So this is somewhat disappointing that this did not provide the expected result for extended adjuvant aromatase inhibition in B42 with a negative interaction p-value. Probably for some of the same reasons we've already discussed in B42 with the BCI translational cohort, which is quite similar to this cohort, by the way. Now, secondary endpoints did have some significant interaction p-values here for Mammoprint low versus high for DFS and for breast cancer-free interval. The interaction p-values and hazard ratios are shown on the far right-hand side of the table. But interestingly, the benefit of extended adjuvant endocrine therapy appeared to occur in the Mammoprint low risk group, not in the Mammoprint high risk group, which to me seemed a bit counterintuitive, but that is the data, and those are the interaction p-values to be sure. So the absolute benefit of letrozole versus placebo was limited to Mammoprint low for both the disease-free and breast cancer-free interval endpoints. Tests for treatment by Mammoprint risk group interaction were statistically significant, however, for these secondary endpoints, which I would consider exploratory, given the fact the primary endpoint was not significant. So distant recurrence by subcategories of low risk based on ultra low. On the left is Mammoprint ultra low versus Mammoprint low, but not ultra low. That's a little bit confusing term there, but that is the low risk group with the ultra lows filtered out. The test for treatment risk subgroup interaction was not statistically significant for analysis of these ultra low and low versus non-ultra low cohorts. Again, looking at these ultra low and low, not ultra low cohorts, you can see that there are some significant interaction p-values for the low but not ultra low subgroups with significant interaction p-values as shown. The 10-year absolute benefit of letrozole versus placebo was stronger, interestingly, in the low, non-ultra low than in the ultra low groups for both DFS and breast cancer-free interval. Tests for treatment by Mammoprint low risk group subgroup interaction were not statistically significant, however. So the author's summary for B42 for the Mammoprint data, statistically significant extended letrozole therapy benefit was observed for the Mammoprint low, but not the Mammoprint high group. The treatment by risk group interaction was not statistically significant for distant recurrence, but it was for disease-free survival and breast cancer-free interval. Absolute benefit of extended letrozole therapy in the Mammoprint low group had a delta of about 3.7% with a p-value of 0.002. DFS 7.8% and BCFI 7% in absolute terms. The benefit appears to be stronger in the Mammoprint low, not ultra low group than in the Mammoprint ultra low group, but the treatment by a low risk subgroup interaction was not significant. And the Mammoprint low, not ultra low represents about 48.7% of the total translational Mammoprint cohort. So in summary, key takeaways from ASCO 2021 that I've shown you: a breast cancer presentation in the plenary session puts ASCO 21 into the win column for breast cancer researchers. Adjuvant PARP inhibition in high-risk germline BRCA mutant early breast cancer is practice changing. It begs the question of who should not have germline BRCA testing. Two august surgical oncology breast cancer committees have made that same determination independently in the past year to year and a half as well. Time to event analysis in Gepard-Nueva holds promise for immune checkpoint inhibition in early triple-negative breast cancer, and hopefully longer follow-up of ongoing studies such as the Keynote study will shed more light on that question. And finally, translational biomarker investigations in B42 are limited by very small numbers of events and subgroups of interest. A high fraction of contralateral new primary breast cancer events in B42, which cannot be predicted on the basis of primary tumor biomarker analysis, resulting in limited statistical power to draw meaningful conclusions. Consequently, the interaction p-value for the declared primary outcomes of BCFI and BCI B42 and distant recurrence in Mammoprint B42 are not significant for either biomarker. NSABP B42 does not detract from the very consistent findings from Stockholm MA17, Trans-Adam and Ideal, demonstrating significant interaction between HOXB13 IL-17B receptor status and long-term benefit from extended adjuvant endocrine therapy. And finally, on the strength of the aforementioned studies, the NCCN Network Panel expanded its clinical practice guideline by recognizing BCI as a gene expression assay for prediction of benefit from extended endocrine therapy earlier this year. With that, I will conclude my presentation. We are at the top of the hour. Thank you for all those of you who must sign off for now, but I'm available for the next few minutes to go through any remaining questions on the last presentation or two. Lisa?
So one of the questions that has come in is, how do you choose between the different genomic assays and the clinical questions that you're trying to answer for your patients?
Personally, there's so much data from Oncotype and the fact that it's included in the AJCC 8 staging system, for example. I find that to be the most useful in practice, especially in the wake of the TAILOR-X data for the intermediate risk recurrent score group, and also in the responder trial for the 1 to 3 positive lymph node group. You know, just in responder alone, here you have postmenopausal patients with 1 to 3 positive lymph nodes. That's a huge swath of breast cancer patients for whom chemotherapy used to be rather routine. And now we have clarity on that question. So I think that's extremely powerful. And none of the other assays have been as impactful to date for the chemotherapy versus not question for ER positive early stage breast cancer, in my opinion. So that's my go-to regimen typically in terms of diagnostic workup, is I'm using Oncotype DX more than the Mammoprint. It's not to say that the Mammoprint doesn't have prognostic significance. It certainly does. In a retrospective cohort published previously, it did show a predictive value for chemotherapy outcomes as well in a cohort of early stage breast cancers. But like I showed you, the MINDAX study failed to confirm that in a prospective randomized fashion. So the only data available are the retrospective analysis to answer the chemotherapy question, in my opinion, for the Mammoprint assay. The extended adjuvant endocrine question for Mammoprint, I think must be considered exploratory based on B42. The declared primary endpoint had a negative interaction p-value. Only some of the secondary endpoints were notable. And so I would say that those are interesting exploratory outcomes, but not practice changing. Those would need to be validated in future cohorts before integrated into clinical practice. We need more data. For the BCI, there were lots of data from multiple prior trials that generated the hypothesis being tested in B42, but the statistical challenges limited any ability to show a difference, even if one does exist. It begs the question, did the assay fail the trial, or did the trial fail the assay in this question? I think those of you who have seen the data will have to answer that in your own minds and decide to integrate this 2-gene ratio assay into your practice based on the available data.
So a question came in regarding the contralateral risk reduction from the B42 data. Although the distant recurrence data seems to be a bit cloudy, this particular physician is questioning whether there's still clinical value in these biomarkers as it relates to contralateral risk reduction. Can you comment on that?
No, none of the biomarkers can predict contralateral new primary disease. Mammoprint can't do that. Neither can the HOXB13 IL-17B receptor ratio. BRCA germline mutation could do it. PALB2 germline mutation could do it. RAD51, ATM, CHEK2, all those would probably be significant to predict risk of contralateral new primaries, but not these gene expression biomarkers done only in the primary tumor. The first part of the question was, is the risk reduction impactful clinically? Absolutely. I mean, the fact that endocrine therapy not only treats the primary in terms of adjuvant treatment, reducing the future risk of relapse, but also prevents new primary breast cancers. That's an extraordinary observation and very clinically meaningful and impactful. And that's the strength of the B42 intent to treat population analysis, is the fact that it reduced second new primaries in the contralateral breast to such a great degree. That's very clinically meaningful and shouldn't be discounted in any way. But it detracts from the statistical power of biomarkers that were not designed to change the event rate of new contralateral primaries.
Wonderful. I've been told that we can continue for a few more minutes with questions because apparently there are a number of them coming in. So
Great.
I will continue with this question. Two of the breast cancer index studies used letrozole as the aromatase inhibitor that was studied. Would you deduce that the results would have been similar regardless of the aromatase inhibitor specific drug used?
Yeah, I really think so. I think all of the aromatase inhibitors are literally like Coke and Pepsi. I don't see any meaningful clinical differences with respect to either their efficacy signals or their safety signals. All three in, of course, their own independent data sets, but the number and types of adverse events are almost identical between all three aromatase inhibitors in big adjuvant data sets. And the efficacy signals are also just absolutely spot on. So I don't think that we would have seen or expected to see any differences should any of the trials used different aromatase inhibitors. I consider them to be absolutely interchangeable.
Wonderful. So another question, this one's specific to the Mammoprint ultra-low data. What are your thoughts on that, on Mammoprint's ability to identify these ultra-low patients?
Well, it's kind of analogous to the Oncotype assay, which originally was developed to classify human breast cancer into low, intermediate, or high risk. And so with Mammoprint, we now have ultra low, low, and high. So it's kind of very analogous to the Oncotype results in terms of just identifying a very low risk group. So I think that's meaningful. Certainly those patients do extraordinarily well independent of their adjuvant therapy even. So there must be biology intrinsic to those subpopulations that are of interest. And it's a reasonable fraction of the total indeed as well. So I think that might, give some help, if you will, to consideration of that assay if you're looking to find a very low patient population. Interestingly, the concordance between many of the gene assays in breast cancer, the concordance rate is low. There was a trial called the Optima trial done in the UK that compared 5 different gene signatures, including Mammoprint, Oncotype, and a number of others, including the PAM50 assay, et cetera. And all of them could call out a low risk group, but the concordance between the assays was very poor. The Oncotype had the highest fraction that were categorized as low risk in the Optima clinical trial, where they used all 5 assays in all 300 odd patients. despite the fact that all of them can call out a low-risk group, perhaps none of them call out the low-risk group, which is what clinicians really need to know and what patients deserve. You know, on the basis of the Optima trial, you could say, well, if I really don't want to give chemotherapy to a patient, I'm going to use the Oncotype DX because it has a higher probability of giving me a low-risk score compared to Mammoprint. That's not right. I mean, that's not any way to make good clinical decisions. So it begs the question, are there future assays that need to be developed to classify human breast cancer more definitively to be able to identify nuances in risk for various subpopulations? Breast cancer is not one disease. It's not high, low. It's not two diseases. It's not three diseases, high, intermediate, and low, or ultra low, low, and high. It's far more complex with that. So these assays are just the first foray into classification of human breast cancer vis-a-vis prognosis or predictive value. And we need much more critical, nuanced assays to be able to elucidate biology. So more to come.
Wonderful. So another question that has come in, if a patient is on tamoxifen for 5 years and then is switched to an aromatase inhibitor, totaling 10 years of treatment, is there any biomarker or testing to determine the benefit of longer duration beyond the 10 years of the aromatase inhibitor?
Not that I'm aware of. I mean, I think there is one trial, if I'm not mistaken, that looked at aromatase inhibition beyond 10, but I don't have any updates on that on the tip of my tongue. So I typically stop at year 10, though for some very high risk patients, let's say stage 3 patients, especially if they're very anxious, some patients have talked me into going a bit longer in clinic, I must admit. But I don't consider that to be based on evidence that's mature enough or abundant enough to make a database decision.
All right, let's see. I think one final question. Do you use extended endocrine therapy in the absence of BCI due to cost associated or other issues with high-risk patients?
I haven't found that to be a problem. Now, you know, the patient population in our area is a bit unique. It's a very affluent area, and almost all of our patients are very well insured. But even the Medi-Cal patients that we do see at our center have not had any issues in terms of reimbursement for measurement of the 2-gene ratio. If you take into consideration the expense of treatment and the expense of all the additional side effects that accumulate during the second 5 years of extended adjuvant endocrine therapy, I think you could make a strong case for cost effectiveness by measuring the 2-gene ratio, because a significant fraction of patients will be found to be low enough risk to not benefit from extended adjuvant therapy, and therefore be a huge cost savings, both drug costs, but more importantly, management or prevention of long-term adverse events. For example, you know, denosumab, Prolia treatment for those patients that have decreased bone mineral density, or bisphosphonates. Those are all expensive drugs. Treatment of complications like pathologic fractures are very expensive, especially if there are major complications like hip fractures, et cetera, that can even be life-threatening. The cost of factor 10A inhibition for thromboembolic risk for patients who have DVTs or PEs on tamoxifen is not inconsequential. So the costs add up so fast for a small number of complications that the 2-gene ratio, I would think, would be highly cost effective if one would do the analysis.
Wonderful. Okay, well, we've got lots of questions coming in, Dr. Pegram, so we'll present one more to you. Do you typically keep patients with 4 or more nodes on an aromatase inhibitor for 10 years without BCI, recognizing that breast cancer index is only intended for patients up to 3 positive lymph nodes?
You know, I think there are some patients with such high clinical risk, locally advanced disease, inflammatory breast cancer and the like, HER2 positive breast cancer, some of which may be inflammatory indeed. Some of those patients I'm probably going to recommend continuation just because the risk is, there's just no question that the risk is very high. Based on nodal status alone, maybe not. I think the total stage consideration may be more important than just the nodal status. So I would still, want to know based on data what the considerations are for extended adjuvant endocrine therapy for patients. If the only decision is whether they had 3 nodes or 4 nodes, I don't think that's probably going to impact their long-term outcome on extended adjuvant therapy. And it would be nice to know if it's going to be impactful based on data.
Wonderful. Well, Dr. Pegram, as always, thank you so much for your thoughtful presentation this evening on many of the very interesting abstracts and plenary presentations at ASCO 2021. And with that, we will conclude our evening. Thank you so much.
Thank you for inviting me. I hope my comments will be helpful to your audience. Thank you.